And welcome to this week's special episode of The Dental Guys, a discussion with Dr. Robert Lemke on the referral relationship with dentists and restorative colleagues. And Wes, this has been a topic we have discussed before, but this I think is a special time because not only is this in partnership with the Academy of Osseointegration, which we're going to get into in just a second, believes in the multidisciplinary team-based approach to quality dentistry, but it's with somebody I think who really gets it, Dr. Lemke. And Wes, talk a little bit about, first off, what does this relationship with the AO have to do with multidisciplinary care, team approach to implant dentistry? Talk a little bit about why that fits so well with what we're going to be talking to Dr. Lemke about today.
Well, the Academy of Osseointegration is an organization that has membership that spans from everyone that could be a general dentist through a prosthodontist, so restoring dentist around dental implant therapy. And then the surgical aspect is paired in there in the same organization. So you have oral surgeons, periodontists, and then you even have people that are GPs that are placing. Maybe you even have prosthodontists now that are placing dental implants. We've even seen some endodontists start placing dental implants, and they're part of the Academy of Osseointegration. So why is it important for the team to come together, right, in a multiple disciplinary, right, part of dentistry, which is dental implants? It's restorative driven surgery, and then you have the surgical aspect of these things. I can't think of a better way to talk about this other than to have a surgeon on to discuss how do we create team? How do we create the multiple disciplinary team, and how do we communicate that with the patient? And going from office to office, John, I think that's what the AO is about developing this team. Every time we go to the annual meeting, you have this restorative track over here, and you have this surgical track. And so, which means that you have people that are teaching surgery, their latest and greatest in techniques, and then you have the latest and greatest in restorative. And here's the thing is that we see a lot of surgeons going over to the restorative track, and we see a lot of restoring dentists, which is where we cut our teeth, going over to the surgical track. Right,
and you see them all come together, which is one thing, I love. The meeting starts off with everyone in the same room, it's everybody, amazing. Restorative and surgical. And then you see this breakout into the two tracks along with the lab and a team track. And then you see everybody come back for this closing symposium, which kind of brings all of these things back together to what is, the highlights and kind of where we are today. The AO didn't start off as an organization that was geared as much toward general dentists. And of course, we both being general dentists, that's important to us to note that in the last 10 years, and I've been involved since Wes and I both, since we got out of school, but in the last 10 years, they've really focused on in getting general dentists involved because they know that the restorative aspect of this often begins at a restorative office. And that's when Dr. Lemke kind of came in here, because we were talking, this was before the last episode we did with him on the science of what's going on with all the COVID precautions. And he just kind of made a comment offhand. He said, I was, had spent all this time trying to find the right masks that weren't counterfeit. And first ones I got were counterfeit. And then once I got the right ones, he said, I started going to my restorative referrals and handing them out to them so they would have the gear. And Wes and I went, whoa. Did you say you're handing out these very expensive, very important masks to your referrals? And he said, he didn't make a big deal about that. And we then, right then, I think, Wes, we both knew that this was the kind of person that may have an understanding of what it takes to put together a team that is based upon helping each other out, mutual respect, bringing each other's level up, like we always talk about on the show, taking things to the next level. And I think what you're really going to enjoy from this discussion is, if you are a surgeon or a restorative dentist, you're going to understand some things about what works in building a team and what doesn't work, what to do if you want to build a relationship with a surgeon, if you're a restorative dentist. What does it take from a surgeon building relationships with referral docs? Because Dr. Lemke's been doing it for a very long time. And I think in the end, you're going to find that there are really not as many quote unquote secrets to this as it is based upon things that are proven, tried and true. It's about relationship. It's about doing the right thing all the time, consistently. It's about knowing that if you are committed to education, really that's where everything comes from. It's about being committed to education first. And it seems like Wes, he kept saying every single time it came back to, where do you meet the people you want to work with the most? You meet them at educational events. You meet them in places where people are trying to better their skills. Those are the people that we want to be working with. And that's why I love AO being involved with this, because that's a place you can go and you can find people trying to do the very highest level.
You know, John, there's no substitute, and we talk a little bit about this. There's a lot to unpack here, but there's no substitute for face-to-face interaction. And it starts right in your backyard, as Dr. Lemke talks about his journey with fostering referrals, developing relationships with restoring dentists. How do you find your favorite restoring doc, and what happens? Like, listen, what happens whenever you become, if you're a general dentist, listen to this, if you're a prosthodontist, what if you become the favorite of an oral surgeon? How does that change your practice? How does it change mine and John's practice? We talk about that in here.
Oh, yeah.
I want you guys to really listen to this podcast. There's a lot to unpack here. I think you're going to pick up some pearls. If you're a specialist, if you're a general dentist, if you're a prosthodontist, whatever you are, I think you're going to pick up some pearls about how to go back and start fostering that team approach that the AO has been about for years. And then after the podcast, we're going to talk about a little more about how you can connect with the dental guys and the Academy of Osseointegration in a special way. So stay tuned for that. So without further ado, here's Dr. Lemke. And welcome to this special show of the Dental Guys. And I am so glad to have a friend now of the Dental Guys podcast, Dr. Robert Lemke, back on to the Dental Podcast today. This is a special AO Dental Guys collaboration, and we are so excited, John, to have him back. Today is a great discussion, John, that you and I have had in the past. And leading up to this, we've spoken with Robert about how he has communicated with his referring doctors over the years, and how they've communicated with him, and then how we have fostered the relationships that we have, John, with our
now, Wes, are you saying that there are sometimes problems?
Well, that's what I'm getting to, John. Why?
And general dentist relationship. I don't know what you're talking about. I'm not really sure what you're referring to. This is a revelation. So yeah, I think
there are problems.
So
and I want to bring,
Robert, welcome
Hello
to the show.
there. Well, thank you for inviting me back. It's wonderful to be with you guys, and quite an honor.
Well, we're excited, and thanks again to the Academy of Osseointegration for helping to connect us together. It's been really fun to get to know you a little bit. So there are occasionally some issues, and I think with this relationship, and let's dive right into that. I mean, we know that our specialists are, they have training, they have knowledge that general dentists just don't have. Now, some of them have acquired, general dentists have acquired some further knowledge, and they have some things to bring to the table, but we want to have great relationships with our specialists. We want to have a two-way street, of good communication, collaboration. And, Wes and I are interested, and our listeners are interested to hear. We connected with you early on, and you were kind of telling us some things you were doing that made us kind of feel like you were doing it right in terms of how you were managing your relationships with referrals. Talk a little bit about what you've learned over your years. What are some things that have worked well to foster these relationships over the years with your referring doctors?
Well, when I first got out, and I was in a group practice for a year, and then I decided I wanted to head off on my own, and so I started my own practice, and that was my second year. And in the building, there was a specialist on the second floor, and he was doing probably like 600 implants a year, just an amazing number. And but he did everything. I mean, he placed the implant, he put on the crown, the abutments. Sometimes even put on the crowns temporarily and sent them to the dentist to just cement. And I thought, no, I want my general dentist to be active. I want them to think out the treatment plans and to figure out what the best is. And so we started having lunches and lunch and learns, and we would bring over staff so that our staff could interact with their staff and the dentist, and it could give me a chance to talk with the dentist and for a little while, and the staff could talk with their staff, and we'd be in separate. So that always worked great to be separate because, you're going to say, oh, yeah, well, you'll talk about staff issues, right? We all have challenges. And then the staff would be on their own, and they'd talk about the doctor. Oh, my gosh. And generally good, because the staff are proud of their doctors that they work with. And then we would get back together and we'd spend 20 or 30 minutes and just do a little hands-on. We'd pull out a kit or a case and look at parts and pieces and, everything from like what driver to use or what torque to use, because there's so many different implant systems. And I found that although the weight that I gained from having all these lunches was not good, that was probably the best. And after I got a little more established, I slowed down on that, and it's a shame because I really got to know the staff and the other doctors, and that was probably some of the best times. Just about 2 or 3 weeks ago, I was with a relatively new referral, and I went over to her office and sat down, and we literally just discussed some cases, and she would show me a CAT scan, and I said, well, hang on, this is how I review it, and I went step by step. And it was really nice because she didn't tend to look at the sinuses or the septum or consider joint pain and things like that. And literally just today, she sent me, I think, two referrals just today. I mean, just sent me pictures from her phone on the CAT scan, took an image, and one was a sinus, another one was a TMJ patient, and last week she must have sent another 2 cases for sinus issues and sinus problems that we had discussed. Are they odontogenic? Are they sinus problems, or from just generalized infections? What the issue is. Anyway, so just sitting and spending time with each other is your best bet. And you guys probably do that. I mean, I would bet within the last week you guys have probably spent what, an hour, 2 hours talking on the phone with the 1 or 2. How many hours have you guys spent?
Yeah,
in the last week.
Yeah, John and I, you
were just at one of your specialist office basically all day last week.
Yeah,
right?
So John and I don't practice in the same practice, but it's interesting because we refer to some of the same people. And I was on Friday, I was at my specialist's office for 4 hours.
Wow.
And the conversation obviously is amazing. The collaboration, working with the assistants there, you begin to develop a certain bond of confidence and trust between the team that's working with their doctor, the surgeon, and then me, the restoring dentist. And I tell you what, you mentioned something that's interesting, and it's this awareness thing, right? It's that doctor that you talked about there that, sent you the first CT and you took the time, right, to actually sit down and beside that doctor and say, look, these are the things that I'm seeing here. And they begin to learn and identify and become aware of what's even possible. And I remember just a quick story here of something that happened in my practice many years ago with the treatment of of periodontal disease. Now, something as simple as that can be really hard for a general dentist really to learn how to effectively treat. And early on in my career, I had a periodontist come alongside of me. John knows who I'm talking about. And he sat down beside me, and he spent probably 2 or 3 hours for months in the evenings coming to my office, showing me cases for months.
Wow.
And spending time with me. And you know what it led to? It led to a relationship that blossomed into, one, I'm able to identify what I can treat because he wanted me treating it. He trusted me because he was teaching me how to treat it in my hands, but he also taught me how to identify what he was capable of, which then led to us having lunch and learns and opening up the team's eyes, the referring team's eyes, because when they would come and get me, they would say, you know, Wes, this is a great case to send down to our local surgeon or our periodontist because we know he can take care of it because they're aware now. I know, John, you've had several instances of the same type of thing.
Yeah, and I like what you said there, Robert, because, Wes and I have said many times, came from an endodontist, well-known endodontist who teaches general dentists to do better root canals. And he said, the best way to get more referrals as an endodontist is to do your endo so well that no general dentist could do it as well as you. And the idea was that, and then you would show them what and it wasn't to show off. It was truly to educate and to say, hey, look, if you want to raise your level, then I'm truly going to help you with raising your level. But at the same time, you're also showing that, hey, you do have a knowledge here that they may not have as much of, and that's not a bad thing. That it's a matter of collaboration. You're showing what's possible, what you can do. This person now says, maybe I need to be sending more of this out. Maybe I really don't know as much as I thought I did, or I'm not quite there yet. So I need to have help. And I think when you start doing that, now all of a sudden it turns into, first off, that person's comfortable telling you what they don't know, which is huge. I feel like when you're comfortable telling your specialist, hey, here's what I'm struggling with. It doesn't mean you're going to necessarily start doing those things, but it's just being comfortable. And the specialist is taking you aside, and instead of just saying, well, don't worry about it, I'll take care of it. They're saying, well, let me tell you what I know. And, so talk a little bit about what can specialists do who are maybe in an area where we talked about this a little bit before the show, that a lot of general dentists are, especially earlier in their career, there's a lot of pressure on them. And that's not an excuse, but there is a lot of pressure to do more and to do everything. Maybe to not refer out as much as they should. And what do you think how should a specialist approach that referring dentist, a potential referral, in a way that could start that relationship or could make that, into kind of create awareness with a new referring dentist of how to start that conversation?
Well, you guys must have been watching my text, or maybe you were on a joint text with me. Literally, I think it was Thursday or Friday of last week, because I had a relatively new general dentist who had joined into a practice, and the owner, who's been out for a handful of years, but the owner really liked to do everything in-house, didn't want anything sent out. I mean, felt that they could do everything. And the new dentist coming in was pressured and felt that they also had to do everything in-house. And I was texting, hey, we were talking about a case, and I said, how was your day? And I got back really bad, I feel terrible. And it's like, why? I said, well, I had an extraction that really went bad. And of course, the first thing a oral surgeon thinks is, well, why didn't you send it to me, right? But I didn't say that. They explained their situation, that they're in a practice, they feel a lot of pressure to do, just like you said, to do it all. And you never know sometimes when you enter in an extraction or any procedure, this is going to be a 3-minute procedure, and an hour later you're still there, especially if you don't have the right tools, or you don't have the handpiece, or if you can't sedate the patient or something like that. And so the conversation with dentist, I explained a few things. And one was, you have to follow your passion and you have to find something that really appeals to you. And you don't know that the first year that you're out. I mean, it takes 2 or 3 years. I mean, you guys have been out for how long?
About 15 years for me.
Yeah, 15 years. Yeah, 15. So I'm counting up here. I'm like, whoa, 16 years now?
Okay.
Like, what?
And I bet when you first got out, you probably tried a little of everything, right?
Sure.
And then how long did it take you before you found areas that you're like, oh, I don't like that? And other areas like, I really enjoy that. How long did it take you?
5 years.
5?
Yeah,
Okay.
I think it took between 3 to 5 years before I felt like I was an expert at certain things, and then there's certain things I definitely knew I was not. I just didn't enjoy, or I wasn't as good at as I wanted to be.
Okay. So I probably underestimated for her. I told her 1 or 2 or 3 years. So I'll after our conversation, I'm going to let her know. But fortunately, all your listeners are that far ahead. Okay. And yeah, I mean, it takes a while. And then eventually you find that it's just not worth your time to try to do the things you don't enjoy. And, the other thing is when you go outside of the realm of general dentistry and you start doing, whether it's endodontics or periodontics or oral surgery, you're held liable to that specialty. So if you're doing endo and your endo doesn't go bad, you're not evaluated to another general dentist. Your case is being evaluated by an endodontist or a lawyer, or plaintiff for that who's an endodontist. And I review cases also for oral surgery, and sometimes they're oral surgeons, sometimes they're general dentists where the cases just don't go well. And we all have that, but of course, we have to weed out, which ones were below the standard of care and which ones were just malpractice or which ones are just bad things happen sometimes. So, or the last category I call where the patients are just crazy. But, trying to decide what area to go in takes a while. And I think that's the most important thing for any dentist. And going to different meetings and going to like the Academy of Osseointegration allows them to see so many different aspects of implant dentistry that they can finally say, I really do like surgery, or no, I'm going to focus on the prosthodontist. But generally trying to do it all is not very practical. Mm-hmm. And so going to meetings, sitting in with your specialist, I mean, you guys spent hours talking. And I guess the thing I wonder always about, because I don't see a lot of general dentists do that, is that I think that they feel that they're losing production time. What's your take on that?
Yeah. I think that's so Wes and I, we're before the AO meeting, unfortunately, was postponed because of the COVID. We're going to be presenting there a topic that we're not going to blow the whole thing because we hope we still get to do it.
Be careful because we want to save it.
But I will say that we feel that's we lament some of the lack of just sitting and having that time to learn at things like meetings where there's not still a quick, easy way to gain that knowledge. And there never will be. There are better ways in terms of organizing it maybe now than in some ways before, than, finding the right slide deck, and the right guy at the right time. It's easier to get information maybe, but it's no quicker necessarily to be able to get good at things or comfortable with things, or as you said, learn what's you're good at. And so I think that, having time, setting aside time for education, setting aside time for conversation with your specialists or with just other clinicians that will, are smarter than you are or have different skill sets, I think is essential to growth. And I think that's one of the things, again, that Wes and I lament the loss of somewhat, with more of the turning toward, learning on YouTube or, what does that even work? Can you learn on YouTube? There's certain things we can learn, online, but there's certain things you can only learn through true interaction. And interaction with your specialist, I think, is huge. It's the way that we learn what we don't know oftentimes, and it's the way that we learn what someone else does know, the exchange of ideas. And I think that, as you're saying, you really have pointed us directly toward the place that I feel we have found ourselves through our experiences work the best, which is just going together with your specialist to meetings and or having just time reviewing whatever it is, reviewing an article that you read, or talking about something new that you read, or talking to the implant rep about a new design, or together though, and having that time of discussion is huge. And Wes, I think you've felt the same way, right? Every time that you've developed a relationship with a specialist, hasn't it usually been around education in some way?
Yeah, every single time. It's always around some event, maybe not even a national event. Maybe it's a local thing that we saw that was put on by a local university or something like that. And we began a discussion about something we saw that week that matched what we saw on the screen. We both decided to collaborate on that, and that led to us doing more of that type of treatment together. And, I'll never forget my surgeon coming into my office. This was right after I'd finished residency and started to practice from scratch. In residency, we restored a significant amount of full arch hybrid prosthetics. Back in the day, in 03 and 04, it was, gold bars and all the crazy stuff that you see. And there for a while, as you start a practice, as a general practice starts, you're not seeing those type of things. And I'll never forget that my surgeon came, he was coming up to my office we actually was doing an uncovering in my office so the patient could just go ahead and have the temporary place that day. And he made a trip, and he was like, Wes, these cases are in your practice right now. And he was like, let's talk about that. And that, from that conversation, and him just telling me these are the type of cases that are in my practice, it just escalated from there. And it always is around some type of learning. I feel like, John and Robert, is that we just see that learning brings people together because, again, knowledge and awareness, and what the surgeon might not know about the restorative-driven part of implants that we know can help complement their surgery so well. And that kind of leads me down to this question is, I know surgeons don't want to be a restoring doctor, right? You don't want to be that guy on the top floor that's putting on the abutments and cementing the crowns temporarily to get the check off from the dentist, from a legality standpoint, that this is a done deal. And so I know that we've driven, treatment planning today from a standpoint of it needs to be driven from the restorative side into the surgery and then come back to the restorative side of things. And I like to refer to this, me being that team member, the restoring doctor, as the quarterback and the collaborator with the lab and the surgeon, or whoever's involved on the team, even the assistants. How do you even, that's the ideal situation, right?
It
and
is.
If we were going to create an ideal referral environment where I'm doing the easy cases, the singles, and you're doing the harder cases, the specialty cases, or maybe I'm not doing any cases. I'm just referring all my cases to you, which is great. But there's such a collaboration now because we understand each other. And I'm quarterbacking that. That to me is this ideal thing. And so,
but you're not seeing that as much, Robert, right?
You're not seeing that,
or are you? I mean, tell us tell us a story, Robert. I want to know, over your years, because we feel like this is getting worse and worse, and we want to fix it. We don't want to just complain about it, but we want to fix it. But what have you seen? Have you seen this push more toward the surgeon being more and more responsible for things which they might not normally be the best equipped to handle?
Unfortunately. And so what happens is, And I can tell you just different examples even the last week where I had a patient come in and there was severe bone loss around an implant and it was a cement retained crown. And my implant was maybe a little lower than I would have liked, but there was bone loss everywhere. And this was a patient who had about 4 or 5 implants for the maxilla, had the teeth in a day sort of thing, had another implant on the other side, but this one had always been a problem. And when I got to look at it, I pushed and pus just came out. And it was probably from cement that worked its way down, but it may have been from food, I don't know. But, chances are it was cement, but of course then you're stuck. Do you tell the patient, well, this was probably the restorative's fault? Well, and it may or may not have been. And of course that doesn't ever gain anyone points. So, you don't know for sure. So you say sometimes it can be cement that was in there. Sometimes it could be food or a popcorn kernel. And the patient says, oh, yes, it's been always hard to clean. I said, well, that's exactly right. So some food could have gotten in there. And what we're going to try to do is open it up and clean it out and maybe try to bone graft it. And that may or may not work, but if nothing else, I'll at least be able to maybe scrape away the popcorn kernel or the cement or whatever it may be. But it puts us in a challenging situation. And I wish more general dentists would just take the time to write out a treatment plan. That would be the goal. If you just, put, me, general dentist, doing this. And then 3 weeks later, specialist A does this, specialist B does this, and then wait 3 months for bone to heal. A little just outline. And that works for everyone. That can work for the specialist because sometimes the specialist forgets where they are on the treatment plan. That can work for the patient because patients like to have an overall picture or image. And I find, unfortunately, that I'm having to do that as the quarterback and putting the dentist's name and what they're doing and the time frame and the little disclaimer that, this is a general plan and plans do change. So the ideal situation would be if the general dentist could just sit down and say, let's create an overall plan, and then the general dentist do it. That would be the ideal situation. And it's hard to get people to do that, general dentists. A lot of times we just talk about it and okay, I'm going to do that. And these are big treatment plans, like you said. There was one case where this was a lady who had an infected posterior molar, 15. It was all part of a bridge. The bridges were failing. And so I sat down with the dentist, discussed different options and said, okay, I'll take that out. And the dentist said, well, I can take it out. I'll have to section the bridge. And I said, okay, well, when you do, don't forget that there may be a oral antral fistula. And so you may want to put in a collagen plug. And they said, oh, well, in that case, you go ahead. Because I just want them to think about that. And I don't mind if they do the case, but I just, we don't want a hole and we don't want them to go down and have problems.
Yeah.
But then the dentist turned around, and this was great, said, well, why don't you at the same time, because these bridges are bad, why don't you do sinus lifts bilateral, and then we can set the patient up so that over the next 4 months, the bone can be healing. I'll evaluate the bridges one by one over time, prep them, take them out, see if they're salvageable or not. And if they are, then great. We'll just turn them into individual crowns and put 2 implants in the posterior. That way it's easier for health and hygiene. If they're not, then we'll take everything out and we'll do a teeth in a day sort of thing. So that was a great plan, but it took sitting down with the dentist. And I can't remember if this was in my office or theirs. And it's always nice to go back and forth and just look at a case and chat about it.
Yeah.
Let me flip the coin a little bit here on you. So let's say that you have this relationship with a restorative doctor, and he's collaborating with you. He's developing the point A to point B plans. You've actually sat down and discussed that we're not going to use cement unless we actually have to use cement. And when we do, we're going to use cement retention protocols that lead to, just better designs. And you've just really hashed out a lot of things. You've just sat down over dinner multiple times and you've hashed all this out. So you start seeing that what was said at dinner is actually happening, right? It's actually proving out to be this true thing. And so then one day, Robert, you have this patient that shows up to your office, and this patient is sitting here and you're like, man, you need some stuff. Like, and the restoring doc over here has been showing you some stuff he's been doing, and you've been seeing his stuff. And you're like, this patient isn't connected to any referring doctor. They came in, they have a severe debilitation and whatever problem they've got. But guess who pops up in your mind? That doctor that's been doing it right, that you've been working with. I'm not saying you're playing favorites.
No.
But what you're doing here is you have a relationship now with somebody that is going to take care of it. In fact, you guys are going to come together, and your two brains are going to meet the patient with an amazing plan, and the outcome is going to be so consistent and predictable. You're going to want to continue to foster. So what John and I have noticed, because we've done this, is that we see referrals coming back to us.
Right.
Yeah.
Now, it's very complex, but we've asked for that, right?
Right.
And even if it wasn't complex, the onesies and the twosies sometimes show up, and guess what, John? It's a simple impression and a screw-retained crown, and we know it's been done right, and those patients appreciate it because it's in and out.
Because, Robert, in the end, what I want, because I feel like we're giving a lot. If you're a restorative doc and you're listening to this, you're probably from one of two camps. Either you are the person who has devoted themselves to that education and you're just kind of cheering this on, or you're the person who's maybe feeling a little convicted by this, but the thing that I think that we don't, as restorative dentists, understand very well sometimes is the position that the specialist is in.
It's tough,
especially as a surgeon, because if you place an implant, and let's say it is a full arch, let's use the high dollar example because it's a common thing we run into. You place the full arch case. The question is, who's going to restore this? And if you know that you have somebody who referred this case to you who really doesn't have the knowledge to do the restorative side, the surgeon is caught in a very precarious situation because you've got a tremendous amount of money and time invested in this case from a surgical side, and you don't have maybe the confidence this is going to be done right. So I want to know, in your case, how do you approach that? When you have that type of situation, you know that the restorative doc isn't giving you a treatment plan, right? It's just all it says on the referral sheet is implants upper, right? And you look at it, it's clear that it's that it's a hybrid type of situation, or it's a full arch treatment type of situation. You present that to the patient accepts, but you don't have somebody with restorative knowledge. Are you relying on the laboratory? Are you relying on your team? Are you educating the restorative dentist directly? How does that work in your experience, because you've done this for a long time?
So a few things. I mean, first of all, like one case, literally today, patient came in and I put in some bone. She for some extractions a week ago, and she came in for her follow-up. But she's been missing number, I can't remember if it was 8 or 9, but one of her maxillary centrals, and she needs a little onlay bone graft, and she doesn't have a general dentist. So, in those cases, there are many general dentists all around me. Literally within about 3 miles, there's, I think, 4 or 5 general dentists. But I know the one that I will probably refer to, because I know when I send them there, there's not going to be any questions other than what type of implant, what size of implant, and that's it. And they will run, and they know what they're doing, and they have taken time to go to courses and AO meetings and whatnot, and they know they're restorative. And I know with the others, I will be at their office and helping them take the impression and helping them remove the crown, and I don't mind that. But sometimes we have to do that. But then the patient wonders, well, why are you doing all the work and my dentist isn't doing anything?
Right.
And we get that question. And then there's this situation where yeah, they say, well, just put in some implants and I'll take it from there, but they don't know what they're doing. In those situations, it's hard because I certainly want to refer back, but we want the patient at the end of the day to have the best of care. And so I'll have to sit down sometimes with them and I say, now look, this is a very complex case. We have to look at their smile line, that they are vertical maxillary excess, that covering the margin for the prostheses and the gingival bone level is going to be a challenge. And I'll go into all the complications and say, are you still interested in doing this case? And at that point, some of them can read between the lines, or they figure out that, no, it's not worth it, and then I will refer on. But once in a while, they say yes, in which case then, I do the conversion in the office. And we have to work with the lab, like you said, who will go into the dental office and try to help them along the way. And that's not bad if they want to learn, but a lot of times I've seen where there just aren't enough of these cases for them, so they may do one every year and they're just not learning, and they forget. And so unless you, again, have a passion for it and you really want to go in that direction, it's probably best to refer out and know your limitations.
Yeah, and I think that's well said, because that pressure, I think sometimes we easily forget about the pressure that you guys are under, because in the end, if that case fails, oftentimes it comes back to implant failures and you're having to rehabilitate. And it's different than in our office. If a crown fails, we can redo that crown pretty easily for a relatively low cost and time. But when we're talking about the failure of a, zirconia hybrid, who's paying the bill here? And this becomes very challenging when it's really not the patient's fault. And we had one of our surgeon friends that has, I think, over 100 referrals, and we asked the question candidly for dinner one time, well, how many of your 100 referrals would you trust to restore zirconia hybrid? And he said 2. And so that was very eye-opening. And you talk to the laboratories, and it's an even worse picture, unfortunately. The laboratories will shoot you even more straight, and they'll talk about how, does anybody know what a verification jig is? Does any restorative dentist know? I mean, there's a few, but most of them just say every verification jig is great. Never, it's amazing. Never have to retake any impressions ever, And so I want to bring this back though, because I think we could spend a lot of time on the bad. We could spend a lot of time on what's lacking, and there's a lot lacking, and it's easy to criticize. But how does I look at the AO and I look at what they're doing? Because the reason why Wes and I got involved years ago with what they're doing is not because it was a general dentist organization per se at that time. Early on, it was a much more specialist-oriented organization. But I see what they're doing with trying to encourage restorative dentists, general dentists, to get involved because they want to up the game of the team. And I want you to speak to that a little bit. If you're in these situations, whether you're a restorative side, surgical side, specialist or not, what's the value of organizations like that in terms of what they're trying to do with evidence-based dentistry especially in the implant world? Talk a little bit about that.
So, over the years, I've attended lots of different meetings. I've gone to state meetings, local meetings. I've gone to my national oral maxillofacial surgery meetings, and they're all wonderful meetings, but they're always pulled in so many directions. I mean, you've got TMJ, and you have, patient compliance, and you have HIPAA classes, and it just goes on and on and on. And what I really just found fascinating about the AO was it just takes dental implants. We're not looking at orthognathics or the joint synovial fluid breakdown, and it just takes implants. But it takes implants across the board, from, like you say, general dentists to periodontists and prosthodontists and oral surgeons and even some endodontists attend, and then there's even laboratory, and then there's the auxiliary staff and students. And everything tends to be more scientifically based and evidence-based. I mean, there's other groups out there that are implant oriented, but they're a little bit more, well, in my hands sort of driven. And the AO is very much science driven. I mean, it's not, well, let me show you my one case. And that's what I really appreciate about it, is the ability to interact and sit down with so many people from all different walks of life. I mean, and I started off, I'm just a private practice oral surgeon who's been going to the AO for many years. And literally, I guess maybe my fault was I never said no. And they said, oh, would you mind being on a committee? And I didn't say no. And then I went on another committee. And before you know it, I think I've been on, 8, 10 different committees and subcommittees. And then I was on the foundation, on the board. But it's because, it's an appreciation I have for all the other people that I work with. There's just all walks of life. And at one point they said, Robert, we lost our moderator for the laboratory section. Well, I didn't even know they had a laboratory section, all for labs. And would you mind moderating it? And I went and I listened to a fascinating guy who had been flown in from England, who was talking about some of the new high-end prosthetic materials for using as a base structure for fixed full arches. And it was just fascinating to hear. And all of that is available to general dentists. Yeah. And that's the beauty, is that's the only place it all comes together.
Yeah, and I like this, the idea that our show has kind of been all about is we feel like the answer to so many of these questions between who does the case and specialists and generalists and just raising our overall game, evidence and science is the answer. If we all can just sit down and listen to the smartest people in the room and read the journals, it's really, things work that have been peer-reviewed. And if we all can just sit down and hear that and listen to that together and then implement that, whether we do it as, a restorative and surgical team, whether you're doing some surgery in your own office and some restorative in your own, whatever it is, it works. And all of a sudden, when you have successes as a team that are predictable, that's where it starts to get fun. And I think if general dentists see that, because the frustration I see on the general dentist side is when you don't know, things don't go well over time. And you're frustrated, and you're running an emergency clinic now because everything's not working and stuff's pussing out like you're talking about. And we go to the AO and we get, okay, here's the state. Like Wes and I say, every time we go to an AO meeting, we will have things confirmed that we're already doing, and then we'll have things that we need to change. And that confirmation, I think, is just as important as the new. It's sometimes, things are exactly the same as they were 10 years ago. And that's also very important. And I think that maybe the problem with, say, some of this newer stuff that's out there on the social media side of things, for instance, is it's sexy, but it may not actually work. And that's the thing AO, I feel like, stands for more than any other organization that I've seen out there from an implant standpoint is, let's talk about what works. Let's talk about what's scientifically based. Have you had some of your referring docs who have attended with you at the AO meetings? And tell us a little bit, if you have, how that's added to the relationship.
Oh, it's wonderful. What I would do is for a few years, I actually would take 2 different general dentists who didn't know each other, and I would bring them together and let them share a room, and I would pay for the room and for their course and for their attendance. And it was really nice because, obviously I was trying to do a little not matchmaking, but, just get similar personalities together. And they became best of friends, and they went out and did things, and they attended the meetings, and then they would talk about cases afterwards. And so it was really nice for that.
That's how Wes and I met, Robert. Our surgeon that we both referred to, we all went to the Astroworld Congress in Sweden. Okay. I had never met Wes in my life. And he invited Wes and I both to go and said, hey, you'll love this guy. And I was like, oh, geez, some other dentist.
We haven't stopped talking since.
Yeah, so that's exactly what you're saying. You know, the specialist kind of made that happen. We owe a lot to that guy for, you know, our relationship as well as our relationship with him.
You know, the one thing too, John, you don't have to go to a meeting to have the AO impact you right now, right? Yeah. As a specialist and as a general dentist, you have access to two amazing journals, right? Mm-hmm.
Yes.
And if you don't know that, I mean, like the AO has its own journal of oral maxillofacial implants, JOMI, and then also now they distribute IPJRD.
Yeah, IJPRD is now an official journal of the Academy as well.
So you could sit down right now, Robert. Mm-hmm. You and I could pick out a few articles, right?
Yes.
You could email them over to, you know, your general dentist, and you could get together and you could have a journal club, right? As geeky as that sounds, I guarantee you there'd be people show up, and you or whoever buys them dinner, right? And you sit down and you have a little conversation. He's like, what's the take home from this, guys? Right? Because that collaboration happens, yes, at the annual meeting, but it could happen right now at a local restaurant, and you could start to foster amazing things. Go ahead.
Right.
Well, and you know, also they have a whole library of webinars. I mean, in this week alone, they're putting on, I think, 3 webinars.
Yeah. High level. And quite honestly, I mean, sometimes I've gotten together with a referral and we'll sit and we'll watch one of the webinars. And I still remember, I mean, one that Craig Mish gave, and it was just wonderful talking about the membranes and what membranes to use or not use. Because a lot of dentists, you know, their patients like, doc, please just take out the tooth for me. I'm right here in the dental chair. And the doc says, well, I should refer you. No, please. And so then the dentist will give in and they'll take it out, which is fine. But know what to do, you know, what bone to use and what membranes to use. And, you know, those courses are just invaluable. So whether it's webinars or whether it's the journal, which is spectacular, or the meetings. And now we're actually working on some future, and I don't know if I should say because it's not yet in stone.
Be careful.
So, well, I'll hold up. I still have to present to the board, but we're moving. But we're moving in another direction just to allow even more networking. In fact, I will say though that the next Zoom meeting that I'm going to be presenting at, we're going to actually have a networking stage for 10 to 15 minutes where people are going to be randomly divided throughout the United States and world into little breakout groups, just as a chance to interact and social network and meet other people and other specialists and other general dentists from throughout the United States and throughout the world.
Wow.
Well, I think it's fantastic. You know, the one thing that the AO is really trying to do here is to try to bring together this team. We've seen it at the annual meetings and how they do have all of the team members there feel like that they're part of that meeting. And now, you know, we see the AO innovating with some of these things that you're talking about. I have a dream that there could be AO study clubs. There could be all kinds of things that could be done here that really foster the relationship and really, you know, all these terrible stories we talk about that really no one wants to happen. Like imagine a situation where we minimize those situations to, you know what, that's a complication of the procedure, right? That's the 1 to 3%ers. And we're not dealing with some of these things. You know, here's the thing, John and Robert, is that dentistry is very unique, and I love it because we don't have a governing agency per se of a written rule of laws about how you do bone grafting and how you place implants and all those things. We don't have that, right? But what we do have is the ability for you and your restoring doc and the surgeons you have to get together, look at the literature, look at the evidence that's presented, talk about what are we doing today and how we're going to do things for the next year in our practice, and then develop our local standard of care for our patients. And isn't that what it's about?
Yeah, it's calibration. It's calibration, you know, and that's what the AO I think is doing really well, and other organizations too, you know, but I think AO is focused on this in the implant specific realm. And, you know, so you've heard it from the beginning, I feel like, of this discussion that, you know, the way to solve basically all the problems that we're encountering or that we're discussing, the challenges, is just through education. And whether that education is through going to an annual meeting, whether it's through attending webinars together, whether it's just by having lunch and talking about some cases that you did, whether it's through showing some CTs to your specialist and just asking their opinion and being humble, to on both sides and saying, hey, I don't know as much about this. Talk to me about what you know. Tell me what you know. Share those ideas. That collaboration, that education side of it is what really is going to, I think, make the difference of how dentistry looks, especially in the implant world, in the next 5 to 10 years, because we have challenges ahead of us if we want to stay not commoditized, if we want to stay based upon quality and have our patients understand that it makes sense to pay for quality. And I think we have a mandate to continue to push that, especially with younger clinicians that are coming out with pressures on them to produce, as we talked about earlier. It's been a great conversation. I mean, this is the kind of thing that hopefully is helpful if you are a specialist and you're trying to find ways to reach out to your referrals or new referrals. Take some of this and think about how this can make a difference. Reach out to Robert. I know you've said before you're available to talk to people about what you're doing in your practice with your referring docs. And if you are a referring doc, this gives you some ideas of how to approach that specialist, to establish that relationship. And also too, to get involved with these educational venues and avenues through these types of organizations like AO. I feel like, Robert, we've just started the conversation with you. I feel like one of these days, we'd love to still have you come back on, talk about what you're doing with Full Arch, because it's something we haven't even really, we've been talking so much more about, philosophy and COVID, we haven't even gotten into talk about implants yet. But thank you again for being with us today. It's been a blast. We really appreciate it.
Thank you. Thank you. And thanks to the AO for all their wonderful support and the ability to help so many people.
Yeah. Well, for Wes, for Robert, I'm John, and this has been another great episode of The Dental Guys.
John, what a great show that we just had with Dr. Lemke. I want to thank Dr. Lemke first for joining the Dental Guys and to discuss, really let us in to what he's done over the years to develop and foster that team. John, I picked up some things from this that really helped maybe confirm some of the things I was already doing, but also some things that maybe I wasn't doing that I could do even better. And I hope that you guys that are listening to this like the show, like the podcast. And we really want you guys, John, don't we want you to give us some feedback? And I think it's important to give the AO feedback. John, talk about how that can happen.
Yeah, if you, what we want to know from these types of shows is, does this create value? We want to create value in your practice from a daily standpoint. And, as we partner with organizations that we trust and believe in, like the Academy of Osseointegration, we will also know that they're interested in the same thing, how to create value in your practice and what type of education you want more of. So first off, to connect with AO, which we'd love for you to do and let them know how you enjoyed this collaboration. You can go to osseo.org and you can contact them directly. You can go to their Facebook page. I know they're pretty active on social media. As you guys have seen, they've been putting up a bunch of high quality webinars over the through the COVID shutdown time and even up through today. So let them know how they're doing and let them know if this podcast has brought some value to your practice. To connect with us, it's pretty simple. You can go to thedentalguys.net. You can check us out on Facebook, on Instagram, on Twitter, all the socials. We are there. And let us know what you thought about this. What are some things in your practice that you have been doing to create relationships with your referring doctors or with your specialists? What's worked, what hasn't? And also, what are some things that organizations like AO can do with the podcast community, the social media community, to connect restorative dentists, surgeons, specialists with general dentists? We know that the landscape is changing and that the general dentists are getting more into this multidisciplinary care themselves. It's becoming sometimes a one-stop shop. But we know that this relationship from having a quality specialist and generalist relationship, this is to us still going to be the foundation of many of the complex cases that Wes and I are going to be doing going forward. And if this is something that's important to you, let's talk more as a group with what we can do to push this idea forward and to continue to foster this growth. So go check us out, give us a like, share this with your groups, with your friends. Let them know what we're up to. Let them know what the AO is up to. And we, of course, as you know, we're going to encourage you to go check out AO. You know, we were, long before we collaborated with the Academy, we were members. It's created a ton of value for me. I know for you it has too, Wes. And we really want you guys to think about joining the Academy. We think it's important to be getting the journals that they offer anyway. Even if you're not doing anything else, just grabbing the journals is well worth the cost of membership.
If you're a listener of the Dental Guys and you're not a member of the Academy of Osseointegration, shame on you, right? Because
no, come on,
yeah, come on,
How
guys.
long have you been listening?
How long have you been
mentioned
listening?
This a couple
we
times?
do. We love to do our Academy of Osseointegration annual meeting recap, and fear not, that will be coming your way next year. It's coming back, right? We had to skip it this year for whatever,
Yeah,
so
you know it.
We're excited about this collaboration, and we look forward to actually this next upcoming podcast. We can't share what it's about yet, but stay tuned for that. And we're excited about what's next with the Academy. They are doing some amazing things. Dr. Lemke couldn't quite share all that was up their sleeve, but I know some great things are coming from the Academy. So for the Academy, for John, I'm Wes, and this has been another great collaboration podcast.